Bismillahirrahmanirrahim. Quote of the day. Nations are born in the hearts of wit, they prosper and die in the hands of politicians. Allama Iqbal. Critical appraisal. I am Dr. Ammad Waheed Khan, PGR, Community Medicine Department. My supervisor is Professor Dr. Saira Abdul. Using a gather checklist for critical appraisal. Article title Update on the Global Burden of Ischemic and Hemorrhagic Stroke in 1992-2013, The Global Burden Disease 2013 Study. Title and Abstract Updates on the Global Burden of Ischemic and Hemorrhagic Stroke in 1990 to 2013, The Global Burden 2013 Study. The title identify as a global burden of disease. Abstract background global stroke epidemiology is changing rapidly, although a standardized rate of stroke mortality have decreased worldwide in the past 2 decades. The absolute number of people who have a stroke every year and live with the consequence of stroke or die from the stroke are increasing. Regular updates on the current level of stroke burden are important for advancing our knowledge on stroke epidemiology and facilitate organization and planning of evidence-based stroke care. This study aimed to estimate incidence, prevalence, mortality, disability, adjusted life years, and year lived with disability and their trends for ischemic heart stroke and hemorrhagic stroke for 188 countries from 1992 to 2013. Methodology: stroke incidence, prevalence, mortality, deaths, and YLDs were estimated using all available data on mortality and stroke incidence, prevalence, and excess mortality. Statistical method and country level covariate data were uh, employed, and all rates were standardized to a global population. All estimates were produced with 95% uncertainty intervals. Results in 2013, there were globally almost 25.7 million stroke survivor, 6.5 million deaths from stroke, 113 millions disability due to stroke, and 10.3 million new stroke over the 1990 to 2030 period. There was a significant increase in the absolute number of deaths due to IS and of death from IS and HS survivors and incident event for the both IS and HS. The preponderance of the burden of stroke continue to reside in developing countries, comprising 75.2% of death from stroke and 81% of stroke related deaths. Globally, the proportional contribution of stroke related deaths and the deaths due to stroke compared to all disease increased from 1990 and 9.66% respectively to 2013. But there was a diverging trend in developed and developing countries and no measurable change in the proportional contribution of deaths and death from stroke in developed countries. Conclusion: the global stroke burden continues to increase globally. More efficient stroke prevention and management strategies are urgently needed to halt and eventually reverse the stroke pandemic, while universal access to organized stroke services should be a priority. Summary: there was a structured summary. The trial design was given, methods was given, result and conclusion was also given, keywords was also given. Introduction. Stroke remain a major global health problem and its significance is likely to increase in the future due to ongoing demographic changes, including aging of the population and health transition observed in developing countries. The Global Burden of Disease 2010 study shows that while age standardized rate of stroke mortality have decreased worldwide in the past 2 decades, the absolute number of people who have a stroke every year live with the consequences of stroke and die from their stroke increasingly increasing. New epidemiological papers on stroke published since 2010 and update death record are now included in the GPT 2013 study dataset. Important advances and refinement have been made to the methodology for driving the GPT estimates. Therefore, this updated report on the current level of stroke burden is important for advancing our knowledge on stroke epidemiology and planning for adequate evidence-based stroke system of care. In GPT 2013 study, we used the new DISMOD methodology in order to provide new estimates of incidence, prevalence, disability, adjusted life year, and years lived with the disability for ischemic stroke and hemorrhagic stroke and other non-ischemic stroke combined separately for 1990 and 2013 at regional and global levels. In introduction, the scientific background was given, specific objective and rationale has been explained. Methodology: we used all available estimate of stroke incidence, prevalence, and case fatality from systematic reviews of scientific literature for population survey and stroke registries. Non-specific cause codes were redistributed based on expert opinion and statistical method. The total for all cause-specific deaths were fitted within an envelope for all cause mortality. Deaths were compiled into 240 causes, including ischemic stroke and hemorrhagic stroke. For stroke death estimates, GPT defines stroke ICD-10 code as IS HS or non-specific as to type. The parent category for cerebrovascular disease was based on the mapping of the detailed causes. Death coded as due to G45 transient ischemic attack were coded as IS and death coded as due to non-rupture aneurysm ICD were coded as HS. Non-specific codes including 165, 164, 167.9, 168.8, 169.42, 169.9 were redistributed to IS and HS using a regression model. An ensemble model was used to estimate a continuous time series for mortality by age, sex, country, and year. Disease prevalence was estimated using the DISMOD state transition disease modeling software and the Bayesian statistical method. IS and HS were modeled separately. Five disability weight were derived from large-scale studies, while SF-12 score from the US Medical Expenditure Panel survey for stroke supplied the distribution of these severity level plus proportion is systematic. YLDs were calculated as the product of disability weight and prevalent stroke. DALYs were calculated as the sum of year of life lost prematurely based on maximum observed global longevity, and YLDS country were stratified into two groups. Methodology describe how the data were identified and how data were accessed. Inclusion criteria was given, exclusion criteria was not given. Information on all included data source and their main characteristics were given. Conceptual overview of the data analysis method given. Detailed description of all step of Analysis include mathematical formula not given. Does not provide the results for of an evaluation of model performance if done, as well as the result of any relevant sensitivity analysis. It describes methods for calculating uncertainty of the statement, state which source of uncertainty were and were not counted for the uncertain analysis. Result and assemble model was used to estimate a continuous time series for mortality by each sex country, developed or developing, and years. Disease prevalence was estimated using the Dismode state transition disease modeling software and Bayesian statistical model. IS and HS were modeled separately. Five disability weight were derived from large-scale study, while SF12 score from the U.S. Medical Expenditure Panel survey for stroke patients applied the distribution of the severity level of asymptomatics. YLDs were calculated as a product of disability weight and prevalent. The DALYs were calculated as the sum of year of life lost prematurely based on maximum observed globally longitude. Wilderness countries were stratified into two groups. Analysis of each specific pattern of incidence, prevalence, and mortality rate by country development status in 2013 showed that IS incident and prevalence rate in developed countries were statistical significantly greater and demonstrated a steeper increase with age than that in developing countries after the age of 49 and 39 years respectively. However, IS mortality rates after the age of 49 years were greater in developing countries. The age-related pattern in increasing in IS mortality rate was similar in developed and developing countries. Prevalence rate of HS were highest in the US and USA and lowest in Latin America, Africa, Middle East, France, Eastern Europe, northern part of Asia and Russia. HS mortality rate were highest in Mongolia and Madagascar and lowest in Northern America, most part of Western Europe, Russia, Iran, Saudi Arab, Morocco, Japan, Australia, and New Zealand. Discussion, we demonstrated that globally from 1990 to 2013, there was a statistically significantly increasing in HS prevalence rate, and in developed countries, the increase in the prevalence rate was statistically significant for both IS and HS. Although the prevalence of IS decreased after 2005, while the increase in the prevalence of HS in developing countries may be related to the high rate of undetected and poorly controlled arterial hypertension, stroke incidence increase, or even better detection of stroke in these countries and increase in the prevalence of IS and HS in the developed countries could be related to the improvement in acute stroke or more effective secondary prevention and greater identification of minor stroke cases, including wider use of advanced neuroimaging, which is highly dependent on universal access on primary care. Although this research was based on most comprehensive stroke epidemiological data relevant to the 1990 to 2013 study period and utilized the latest advance in the Dismode MR stroke modeling technique. It was not free from some limitation because deaths were not available for all countries. Mortality estimated relied were not available for all the countries. Mortality estimated relied on geospatial statistical model based on country-specific information. There was still lack of Sufficient epidemiological data and stroke in most countries of the world, particularly in the developing nation. To address this limitation, we use country-level covariate data and applied out-of-sample validity testing to assesses mortality and model performance. Statistical model of stroke incidence and prevalence also relied on Bayesian methods and all available data on incidence and prevalence for each type of stroke. In particular, data from the subnational region were often assumed to represent an entire country. Results and discussion, the indicators like population, age, sex, geographic entities, and time period for which estimate was made were given. Funding source for the work was not given. It does not provide published estimates in a file format from which data can be efficiently extracted. It interprets results in light of existing evidence. Discuss limitations of estimates, include a discussion of any modeling assumption or data limitation that affects interpretation of the estimate. It does not provide all data input in a file format from which data can be efficiently extracted. It report a quantitative measure of the uncertainty of estimate strength. Title is self-explanatory with type objective and type of study, abstract structured,